One of the glories about iliac intervention is they stay patent for a long time, and the patient really feels better afterwards. So it's always a very rewarding procedure.
Dr. Mohan, thank you so much for setting the stage for how to do a good intervention and CTO of the iliac. You promised us one or two cases, so we'd love for you to walk us through your approach of those complex intervention.
Thanks, Sam. Yeah, actually, I have two cases here. Interestingly, one was I had to look back. It was from when I first started as an attending in 2020, and then I had one just recently in October. And I put them both together because I thought it was very interesting how similar they were. And these are kind of the cases that you will probably see as a practicing interventionalist as you encounter iliac CTOs, but they kind of always seem similar. They have a lot of similar aspects, so I thought I would highlight that. This was a case that we encountered, actually, a really nice gentleman. He had really significant claudication that his primary care physician kept attributing to lower lumbar spine disease. He wasn't a smoker, surprisingly, but he was a bad diabetic. And so we did an ABI, just like you mentioned earlier. ABIs were 0.95, 0.94, but significantly diminished waveforms throughout the left lower extremity and also on the right lower extremity. So that made me very concerned that, hey, maybe this lower back butt pain he was having was actually maybe some aorto-iliac disease. So we did a CTA. It was suggestive of heavily calcified iliac disease, but they couldn't tell us much more. And this was actually what we imaged with a 125 pigtail from the left radial. And here you can see pretty nasty iliac disease, not only because of the lesion, but also because of how tortuous the iliacs were, almost coming off at a 90-degree angle. And you can see, I'll stop it here, but you can see pretty tight lesion within that right iliac, common iliac. It's a little bit ectatic and aneurysmal. And then the left actually is a CTO, short segment, probably about 10 millimeters. But CTO, and there is a little bit of a nice nub here from the radial, which we'll show a little bit later.
I think
So
it's
then,
important you mention something here really quickly. This is a post-stenotic dilatation, so you got to be careful because the other vessel doesn't look as big, and maybe you're going to show us. I'm not sure if you used IVUS in this one, but I think maybe this is one of those examples where IVUS is extremely important to highlight the true size of the vessel.
yes, absolutely. That's a great point. And then that also highlights sometimes where you're going to have a landing zone, right? And then how aggressive you want to do with post dilatation. So I'll show that in a second. This is actually what I did next was I put a sheath up from the right side. So you could see the tip of the sheath in the aorta from the right side. And then I got access on the left. And just like I mentioned earlier, I kind of try to probe and see if I can potentially cross from the femoral, but because of how tortuous that femoral was, it just really was not going well. So I tried for, maybe 5, 10 minutes. I kept prolapsing into this internal, and I didn't want to damage the internal or cause any other problems. So I kind of bailed out on trying any further attempts from that segment there. Um, so next, what I did was, what was my step? I thought, I'm struggling to get from the ipsilateral femoral. I think I see a nice nub, as you can see here in the radial or in the aorta going down into the iliac. So what we did was exchange over a stiff wire to the R2P sheath. So you can see that here. And I followed it with a 035 CXI catheter, and then an 035 Glide Advantage. And actually, surprisingly, was not that challenging to pop across that cap, and the wire actually found itself into the internal. And then we later repositioned it into the So what I usually do, like I said earlier, is I externalize the wire. So I actually wired the sheath in the femoral. Didn't have to snare it. It actually surprisingly went right into the sheath. One caveat I'll tell you, and I know Sam, I don't know if you've ever run into this. One of the reasons I do like the destination sheath is because you can detach the hub of the sheath and the diaphragm. So it's really nice for externalizing your wire. But I think I had a cooked sheath here, so I had to MacGyver cut a guide and put a hollow tube in to get the wire out. But we got the wire out, and then once we externalized the wire and did a body floss, we then went up with our sheath in through the CTO on the left leg, and now we have bilateral sheaths in going across the lesion. And just like you mentioned, the next thing I do is I IVUS. So I sent the IVUS up. Typically, I'll use an 018 IVUS or an 014 IVUS. I think in the iliacs, the 018 has a nice role because of the field of view. Sometimes the iliacs are too big to see. Important caveat for the early interventionalists is you can't use an 035 IVUS most of the time. It's a, 9 French, 8 French sheath. So usually you need to use a smaller IVUS, but sometimes that's a little bit frustrating because you have to switch out your wires. So after we IVUSed both sides, we then went with our standard angioplasty. Started with just a small balloon to create a lumen. And then we do our image here, and we can see we're starting to gain some of that flow back into the CTO iliac. And then here we start by doing our kissing balloon inflation. And actually, I'm sorry, that was the delivery of the common, that was the delivery of the covered stents. So I used IVUS to size both common covered stents here. I believe we used 8 mm stents and then post dilated them as you mentioned earlier because I had bilateral 7 French sheaths. And then this is what it looked like at the end. So I was very happy.
That looks beautiful.
One thing I did do is take a smaller balloon. I didn't show that here, and I post dilated just the edge of this stent because of that post-stenotic dilatation. But I think it looks pretty good. Followed it with IVUS, and it looks great. One thing I'll say for operators is sometimes if you have an aneurysm, it's a good reason to stop and consider an EVAR at that point because you have to remember this confluence that you're going to be dealing with in the future may become a problem. So extending those covered stents too far into the aorta could be a problem. So always keep that in mind. But
Okay,
I
so
think
so
here we
basically,
were
what you meant, you can do an IBL, you can do a balloon, and bring the patient back and just do an EVAR, basically,
correct.
to get
Yes, correct. And I
state the
think
procedure.
yes, and I think that's something a lot of operators need to have an idea about. I don't personally do EVARs, but I know, I have no problem sending for EVARs, but I think as a peripheral operator, sometimes you want to get everything done yourself. But remember, if there's an aneurysm there, I think you're doing a disservice by just doing the iliacs. So that might be a reason to, maybe stop, realize, maybe this patient needs a multidisciplinary approach and consider, an EVAR if needed.
Excellent. This is a beautiful case. So I don't know how we're gonna beat this one, because this is a really, really nice case. So excited to see the next one.
Yeah, so case two, that was an older gentleman. This is actually a younger gentleman. He had previous peripheral intervention. You can see here there's an external iliac stent, but he came to me with similar presentation every time he was walking to the casino. He got a lot of posterior calf pain and thigh pain. We did an ABI. It was significantly abnormal for this one. And CTA demonstrated a pretty long occlusion CTO on the left leg once again. And here you could see same approach. We take our 125 pigtail, do an aorto-iliac angiogram, and then I have a wire now into the affected iliac. This one doesn't look as nice in terms of a cap for crossing of the um, from the radial. But this is another good point is always take multiple views. So different, if you take a contralateral view, sometimes it will outline that nub for you. So what we did next was we tried to cross, and this is a good example of, where you can get into trouble a little bit. So I tried with a gold tip glide. And here you can see, I was like, oh, felt very comfortable. I felt like, okay, good. I'm probably in the aorta. But the problem was my wire didn't freely go up. So then I realized do a contralateral view, and I am not in the aorta. If anything, I'm running alongside of it. So definitely in a dissection plane here. So at this point, instead of pushing my wire further or trying any other attempts at this femoral, and here clearly you can see my wires in no man's land. So this is not a good feeling when you see this. But fortunately, it's one of the reasons why I used an 018 wire here. I think that's actually an 014 wire, but I didn't want to jam a bigger microcatheter or follow it into a place where I knew could have been a problem. So I stopped there and just left my wire as a marker. And then I took my Radial R2P sheath, and now I'm just basically probing to see if there's a cap. And you could see maybe a small cap here. And that's what we did. We were able to actually probe down, and then we were able to transverse
Yeah,
that
that
CTO.
wire in no man land. I think most of operator will just pull that wire. I think that other people would pull that wire, and I think that's a mistake. What you just did here is phenomenal. It helps you kind of figure out where that nub is.
Yeah, exactly. And also, sometimes the wire itself is tamponading wherever it's at. So I always, in my mind, it's controlled. He's stable. It's not causing any problems at this point. So I was just very reluctant to pull it. Um, and then once I feel comfortable that I'm going to be able to get a covered stent into whatever segment I'm going to, then I feel comfortable pulling it at that point. And then here, unlike the other one, we actually, you can see a pretty large dissection at this point here, probably from our femoral attempts. But here I snared actually the wire from the radial and externalized once again. And then there, it's the standard approach, balloon angioplasty, IVUS, and then so sending the IVUS here. And then once again, bilateral covered, uh, kissing covered stents. And then I finished with a self-expanding stent in that segment of dissection that I mentioned earlier. Like, once again, this is one of the reasons why I like having that bright tip. I can pull it all the way back to my arteriotomy site, knowing where I am, because I had to come all pretty far down. And then just finished it with post balloon dilatation, and that was our final. And this guy is actually doing great. And he's once again, one of the glories about iliac intervention is they stay patent for a long time, and the patient really feels better afterwards. So it's always a very rewarding procedure.
Excellent. That looks great. Oh, that's really, really good cases. Thank you for sharing this, Jay. I really appreciate it.
Yeah, absolutely. It's one, like I said, one of my favorite interventions to do. Surprisingly, on both those cases, I did not use IVL. I didn't find the need to have to do so. Um, there are multiple cases where I have just those two. By IVUS, there was 180-degree arc, and I got full expansion. So you don't always have to do IVL in the iliac space. I think it's a very useful tool, but it's not always needed.
I think what you mentioned, the IVUS is really a game changer. And if you see a 360 calcification, there's no harm to do IVL and then follow with the cover stent. Jay, thank you so much for your time today. It was an honor, privilege to talk to you today. I think our audience has learned a lot. I appreciate all your insight, and hopefully we can get you back on MurmurMD on a different topic at a different time. Again, thank you so much.
Sam, thank you so much, and I think I'll be seeing you in January
Yes,
in
sir.
Orlando.
Yes, sir.